and increased in information that it has to handle. So increase in synaptic connection lead to hyperactivity of various neural cell body as well as increased transmission across synapses. Whenever synapses face increased electrical transmission, they have to produce a lot of proteins to carry out the work. They have to produce a lot of snare complex protein. They have to produce a lot of vesicular protein so that vesicles can discharge and deform. They have to produce a lot of nasal bodies. They have to produce a lot of receptor the channels which act as receptor for various molecules and ligands. So ultimately, they need to increase their transcriptomic activity. And this is known as electrotranscriptional coupling at synapses. And this creates ultimately hyperactivity of various neuronal cell body. The main areas which are responsible for handling the specific demand works more, but the rest of the brain areas do contribute. And this hyperactivation needs energy to maintain the action. So neural cell metabolism starts increase with increase in mitochondrial oxidative phosphorylation and increase in oxygen and energy substrate demand of neural cell, along with increased protein recycling, which can be summarized in the picture. I would go into a different picture though. This picture. So there will be increased homeostatic load followed by high information carrying load followed by hyperactivity of brain areas handling the load, resulting in increased cellular protein recycling and ER stress. Also, there will be increased mitochondrial oxidative phosphorylation, which would result in redox stress and cellular stress, and ultimately these two would contribute to cellular stress sensing by NOD-like receptor, RIG-like receptor, and various other intercellular protein receptor, which actually are cellular stress sensing receptor. They would be activated by it, and then there would be activation of DAMP pathway. Now, DAMP pathway full form is damage-associated molecular pattern. It is controlled by MyD88 cellular protein and various other heat shock protein, that heat shock protein 90 and other thing. Now, this pathway, when it gets activated, changes cellular immunogenicity and causes activation of various immune cells in brain, primarily microglia. Now, when these pathways are malfunctional, there would be hyperactivation of the resting microglia, resulting in increased formation of microglia pro-inflammatory form, which is known as AM1, and decreased formation of microglia anti-inflammatory form, which is known as M2. So M1 and M2 balance changes. Now that causes amplification of inflammation, innate inflammation specifically in brain. Then there is coupling of this innate and adaptive immunity, resulting in hyperactive cell damage as well as activation of NLRP inflammasome and various other pathways, which ultimately would lead to cellular death, cellular overactivation, and other things if these pathways are not working. If these pathways are working properly, then microglial activation would cause activation of astrocyte and secretion of various vasoactive peptide, along with activation of NLRP inflammasome, normal activation of NLRP inflammasome in the real cell, And this would result in dilatation of the cerebral arteries in response to brain's increased metabolic demand, and there will be neurovascular coupling. Those of you who are interested in various neurodevelopmental symptoms, by symptoms I am meaning attention deficit or autism spectrum, you would come across a so-called biomarker that decreased neurovascular coupling. That is one of the biomarker of autism or ADHD, or in fact so-called schizophrenia, so-called bipolar, because I am using so-called because none of these things exist outside pages of DSM or ICD. In molecular neuroscience, molecular psychiatry, and real psychiatry, these things are just symptoms, not diseases. Anyway, so neurovascular coupling occurs through distinct, and neurovascular coupling derangement occurs when there is excessive activation of NLRP3 inflammasome or excessive interaction between microglia astrocyte and inability of astrocyte to suppress microglial activation. These are the microglial sensomes, and you can see there are thousands actually. I have just listed a few. There are thousands of various ways microglia can be activated, and any of the pathways, if are not working properly, would cause excessive mitochondrial activation and derangement of the whole thing, and every psychiatric abnormality. When the microcyte astroglial interaction is not correct and astrocyte input is getting hyperactivated along with hyperactivation of pericyte and endothelial, there are lots of interesting phenomena that can happen. One of them is a headache, which happens due to spreading inflammation of vascular wall, along with spreading excitotoxicity in brain, which causes a spreading cortical excitation followed by spreading cortical depression. And these sensation would be carried by various sensory divisions of trigeminal nerve, which supply the autonomic innervation to cerebral blood vessel and which carry the sensation from cerebral blood vessel. So there would be a form of headache which would be pulsatile, which would be associated with inflammation, which would have transient overall cortical activation, which would produce aura, and followed by cortical spreading depression, which would result in decreased brain function, social withdrawal, photophobia, phonophobia, intolerance to any environmental stimuli, and withdrawal behavior. This is vascular headache syndromes, and it would include SUNAC or SUNACD headache or SUNA headache, depending on how the trigeminal nerve is irritated, how much, or migraine, or cluster headache if it is occurring with season change due to involvement of various circadian rhythm genetics and other things. So you see, if you go via molecular pathways, you can explain every psychiatric symptom. Now, by activation of microglia, a lot of other things happen. Modification, there will be modification of extracellular matrix and limited resolution of perineural net, which would result in neuronal ability to develop new synapses. Because normally there is a condensation of extracellular matrix around the neuronal cell. So when there is microglial activation, the activation produces pores in the perineural net so that neuron can develop new synapses. If there is excessive microglial activation, the perineural net would be almost completely dissolved, resulting in aberrant synapse formation, aberrant neuronal excitation, and formation of various excitatory phenomena. Excitatory phenomena means whenever there is seasonal change or whenever there is trigger to brain would get excessively activated and produce downstream autonomic activation and tachycardia, tachypnea, peripheral vasodilation followed by vasoconstriction, diversion of peripheral blood to central blood, increased afterload resulting in increased diastolic pressure, diaphoresis means or hyperhidrosis means increased sweat production. There would be GI system disturbances in the form of upper GI stasis, lower GI hypermotility, and stasis alternately, and resulting in stamp of irritable bowel syndrome and other thing. This would be the first thing of the hyperexcitation syndrome. There would be also other thing like increased cerebral vigilance or hypervigilance, followed by suspicion, followed by increased rumination, followed by excessive talking, followed by decreased sleep due to autonomic activation, and overactive arousal promotion system, and ultimately the person would be delegated to either with the stamp of mania or stamp of psychosis. But again, this is part of the overexcitation syndrome. Now, microglia, if there is microglial activation, there would be also activation of neural proliferative zone. There would also be activation, means there is activation of neural progenitor and neural stem cells. There would be increased neurogenesis and gliogenesis. These new neuronal cell and new glial cell would migrate to zone of hyperactivity by active and passive neuronal migration. This neuronal migration is controlled by various neuronal polypeptide, various polypeptide of so-called coagulation system origin, various polypeptide of so-called immune system origin. So, if you think clearly, you would understand that is how complement C4 got tangled into schizophrenia, because complement C4 is one of the chemoattract. Similarly, all the immunokine and chemokine, they are part of this neuronal migration. That is why in so-called schizophrenia, so-called autism, so-called neurodevelopmental disorder, there is migration defect and defective neuronal migration.
5 minutes, sir.
Yes, I am nearly ended. So standing there, we have to think beyond our DSM-ICD scans. Now these neuronal cells settle down in zone of hyperactivity and there is synaptogenesis. And synaptic remodeling and in the form of long-time potentiation and long-time depression would result in neuroplasticity and cerebral arrestation of homeostatic load occur. This is the basic molecular understanding of what happens in brain normally and pathologically. Because this, let's say, there is hyperactivation of microglia and there is hyperactivation of cerebral immune cell. There will be more pruning. There will be less long-term potentiation and there will be memory disturbances. Every psychiatric symptom can be traced to this molecular pathophysiology. So standing there, it is imperative that we start understanding molecular basis of psychiatric diseases. I am not going into molecular action of our so-called psychotropic, which I prefer to call as neurotropic drugs or syncotropic drug. And I am not going into details of how and when to choose drugs to treat a patient, because that would be purview of my partner. Thanks for trying to understand what is happening in brain. I hope I have not bored you, but if you are bored, I don't mind. Nachiketa, you can take over.
I request our esteemed chairman to say a few words.
Yeah. So, as psychiatrists practicing in the 21st century, there is no doubt that we have to make sense of how the brain impacts or manifests in a whole set of symptoms, and how the medications that we give make a difference to what we do. I'm sure there are myriad questions, but our plan was to have the questions together at the end so that we can organize the time better. So now we'll request Dr. Malay Dave, my good friend, to the next speaker to take on and present the last part of this presentation. And I'll request all the speakers to be available for questions in the end. Dr. Dave, you have 30 minutes.
Good afternoon, everyone.
So, do we have Dr. Malay Dave's introduction, please?
Can we have the slide, please? Dr. Nachiketa.
I'm just trying to find.
I think just let's
One minute.
Dr.
One
Malay
minute.
Dave is my colleague.
I have to ask one thing. I was not present, so was I been introduced very
So the whole
No,
point.
sir.
oddly? Okay.
All right, let
So-
me intervene here.
Let
If
me.
anybody who needs an introduction to either of the speakers, that person is not really required to attend the CME. In this era of science overriding presumptions in mental health care, many people have made fundamental contribution to helping the rest of us change our orientation. Dr. Shobhit Ray demonstrated very clearly how he has applied the realization that brain is the site of mental illness into treatment strategies effectively. Dr. Bhaskar Mukherjee has been a proponent, a very aggressive proponent, if I may say so, of the concept of molecular psychiatry translating into healthcare. In fact, at times, Dr. Bhaskar has been so emphatic and aggressive that other people have chosen to keep quiet. Dr. Malay Dave is my colleague. He is by age, somewhat junior, but by maturity, way ahead of me in clinical practice. I've known him since his days of residency, and he never ceases to teach me something every time he speaks. He's simple and he's going to make case-based presentation today. Mr. Chairperson, sir, you take over, sir. Dr. Alim and Dr. Kaushik.
As you are aware, there has been a bit of a mess up with the hall 1, hall 3, this, that, and the other. So without further ado, over to Dr. Malay Dave.
Good afternoon, everyone. Good afternoon, chairpersons, Dr. Kaushik, Dr. Alim. Good afternoon, moderator, Dr. Nachiketa. And first of all, before I begin, let me thank the organizers for making me a part of this session on molecular psychiatry. Before I start, let me make it will be clear when I present, but just as a kind of how would we put it, a pre-warning that it is not actually case-based, because when we look at biological psychiatry, molecular psychiatry to be very specific, all the signs, symptoms, they kind of, they just float away, and we are left with actually processes not going correctly and multiple things going towards the development of a symptom or a syndrome. So I have not, I felt that maybe a case would not be a very appropriate thing. But what I'm going to try to do is give a kind of a snapshot as to what are the clinically meaningful things that are happening that we need to look into, that might become, so to say, hardcore and we'll be able to put or implement in our practice. Because at the moment, whatever's said and done, we know quite a bit about what molecular psychiatry is doing behind the scenes. But I think for it to be in the so-called clinical limelight, I'll share my screen now with that little bit of an introduction. Stop. Okay. Is my screen
Yes, sir.
visible? Yeah.
It
Okay.
is.
So I would just request the moderator that when it is around 20 minutes or 22 minutes, just give me a warning sign so that
Okay, sir.
we can finish it off and we'll have time for questions. So I'm going to talk on clinical relevance of molecular psychiatry. Now, after a very basic understanding of what molecular psychiatry is by my friend Dr. Bhaskar Mukherjee, who spoke before me, for most of us, basic sciences tend to be very intimidating, difficult to understand, especially when we go through papers, when we go through various presentations. And then sometimes, especially in our field, it raises a lot of questions as to how we are going to apply things clinically. So for whatever it is worth, let us see some of the things. What I have tried to do is I have kind of made this 6 headings, of which the first 4 are important because they are directly clinically, so to say, applicable, and the last 2, 5 and 6 are noteworthy. So something about that. So we'll start with this epigenetics and genetics. Now, why epigenetics and genetics? Because if you look at it, epigenetics, or rather genetics, is the source of all molecules that are there within our cells, and that is what we are made up of. And we are actually only molecules. If you look at the very basic design of life, we are complex and complicated molecules. Everything happens that is going to happen, and that is happening is basically an interplay of molecules with the environment, so environmental effects. But where do these molecules originate from? Well, basically we have our DNA. That's the just one second, I'll get my pointer on. Yeah, so the DNA that is there in all our cells, including the neurons, including the skin cells, including the cells of each and every system or the organ of the body. DNA is in the nucleus. It leads to the production of pre-mRNAs or pre-messenger RNAs, proper mRNAs, which go into the cell and are converted into proteins and non-coding RNAs. Now, these proteins, which are formed in the cytoplasm of the cell, then takes on various functions, whether it is supporting the cell, so that is the cytoskeleton or the skeleton of the cell, the various enzymatic processes, the various organelle structures, and so many things. So we are, so to say, after the discovery of the DNA in the about 50 years back, 60 years back, we have basically begun to understand, and this understanding is universal to all of medicine. So it's if we are not looking at molecules, so to say, in psychiatry, we are actually losing out on a lot of stuff because of the various things that even Dr. Shobhit mentioned, that when it comes to therapeutic modalities that we can offer our patients for our various illnesses, we sort of seem to have come to a dead end. There's nothing more happening in terms of, or rather nothing very exciting happening, nothing very earth-shaking happening in terms of the pharmacotherapeutic agents that we have. We have been treating patients all our lives, but we see a lot of non-responses, partial responses, side effects. Even when we talk of diagnosis, we'll come to that later, and I mentioned it before that. I mean, the diagnosis that a patient has is not actually only DSM-5 TR or ICD-10. It's always going to be mixed with a lot of elements. Some of these elements we can actually figure out easily and maybe try and intervene, but a lot of other things are beyond our scope of addressing, especially when they're happening at a micromolecular level. So, well, we are a lot of proteins, so we are actually a lot of molecules, and that makes sense for us to focus on our molecules. Now, when we look at our molecules, one thing that we have when it comes to genetic, how would we say, manipulation is this technique called as CRISPR-Cas9, basically which won the Nobel Prize, Dr. Jennifer Doudna in 2020. And basically with this technology, we have brought about life-changing therapeutic modality for a few disorders, and unfortunately none of them is a psychiatric illness at present. But this remains it's a very important, a very good tool for some disorders. And if we understand our molecules better, if we understand our cells better, maybe it will offer some scope for treating illnesses that regularly feature on the top 10 or top 5 of those WHO problematic diseases, like DALE, measured quality of life maybe every few years. So depression, psychosis, and things like that. Now, that was a very kind of, so to say, a brief introduction as to what are the molecules, where do they come from, and why do we need to focus on them. Now, what is also important is when we look at it clinically, and this is all our experience, general cognitive intelligence is, or general cognition or intelligence is substantially heritable. Means the cognitive functions that I have right now, the way my cognition is functioning, the way my cognition has developed, has got a lot of genetic base. It's a heritable trait. And this cognitive impairments, cognitive impairments and intelligence decline are the core features of schizophrenia, which are evident before the onset of the illness. So if we are really able to look at a lifespan approach for our schizophrenia patients, before the symptoms develop, the typical symptoms that brings the patient to us, which is not the only feature of schizophrenia, which is actually the, how would we say, the features that show up, which are problematic, which the relatives notice, which are troublesome. So even before those symptoms are present, a long time before that, when we look at the developmental trajectories of patients with schizophrenia, cognitive impairments, subtle cognitive impairments, subtle developmental anomalies are found. But because of the way we look at illnesses, because of the limitations of our tools, we are not able to find robust 1-to-1, 100% kind of correlations. But well, the genetics overlap is probably a very astute clinician can make out. So large-scale genome-wide association studies, more than 30,000 patients of general cognitive function in schizophrenia, have suggested that there are polygenic components. This is what we know, and this is proven time and again, that there are multiple genes, multiple genetic variants of these genes, which have got small effects. So there would be, let's say, about 100 loci for general cognitive function, 108 loci for schizophrenia, and many of them will be overlapping. Now, these genetic variants are densely expressed in brain tissue. So it's not one area of the brain, but generalized all over the brain. And schizophrenia-related genetic risks are consistently correlated with lower general cognitive function. Now, what is the idea behind this? The idea behind this is that when we look at somebody who has got schizophrenia, we would probably focus on delusions, hallucinations, behavioral problems, negative symptoms, because we have treatment modalities for that. But when we look at the background, we look at the past history, and when we look at these things, general cognitive impairments, subtle impairments. Now, what do we do about it? I mean, of course, we cannot go back in time, but what we try to also need to focus on is that whenever a child is got to us with some certain issues, that is the time when we start looking for these things. Now, this doesn't necessarily mean that we are going to be able to prevent things. We will not be able to prevent things unless our understanding is 100% certain, and our technologies, let's say like the CRISPR-Cas9, is 100% going to work. Till that time, maybe the prevention is not there, but this is how it is going to be. If we really need to look at an illness, we need to look at it far earlier than the common presenting times. That is one. Okay. Second thing is when we look at serotonin. Now the serotonin is a universal neurotransmitter. It's found everywhere in the brain and including the central nervous system and the peripheral nervous system and the GI. Now the 5-HT4 receptor, serotonin 4 receptor, like many of its other friends, is implicated in mood, especially depression, anxiety, food intake. So basically conditions like obesity, anorexia, memory loss in Alzheimer's. So it's a lot of conditions, normal functions and conditions where this 4-HTR receptor is implicated. And again, it has got an expression pattern which is quite widespread. So forebrain, caudate putamen, the hippocampus and the cortex. Now, basically, what does it do? It has got a role in executive function and reward-related function. So why I said I'm not going to look at a case is because when we look at the case, it will be about low mood or worrying mood, or let's say in this case, Alzheimer's, recent memory impairments or episodic confusion or disorientation. But what it means at the brain function level is there is something going wrong in the executive function and reward related actions. Because this is where this 5-HTR is implicated. This is where it is actually getting studied. So what do these studies suggest? That this 5-HTR expression in brain regions is there. These impairments are there. This not normal kind of functioning is there in brain disorders, but it is also caused, a change is caused in their functioning by drug treatment at both the transcript and protein level. So whenever we are using a psychotropic drug, maybe on 5-HT4R, I don't know what I don't know exactly what agents are available because most of our agents are 5-HT2A, 1A or 3 at the most. 4 is probably in the pipeline. Now, when this receptor is targeted for all these things, this is experimental. So it might not directly, I probably will not give you any advice as to use some agent for 5-HT4R manipulation tomorrow onwards, or maybe today evening onwards if people are able to have an evening session in their clinics. But what we need to remember is that this causes if there is a treatment modality, that it can cause a change not only in the function. I mean, it's not just receptor blockade or an uptake inhibition or something, but at both transcript and protein levels. Forget 5-HT4R, but time and again, studies have suggested that all our psychotropics have this kind of an action. We believe and we are happy with the fact that I give some psychotropic to the patients and 4 to 6 weeks of time, and then there are certain receptor changes. Whatever it has happened, because this is that upregulation, downregulation, changes in neural plasticity, but it's a very superficial level of plastic change. What happens deep down is at both transcript and protein levels. So our drugs actually have an effect deep down, more at a nuclear cellular level, because unless and until there is some effect on DNA function, there is not going to be a change in the protein output. It's actually not going to be a change in the number of receptors or the type of receptors. So it's not only the upregulation or downregulation as we would think. The effect of drugs are deep down. Okay, it's basically a nice map of, so that those first 2-3 were the genetic some things that actually grabbed my interest. What is also interesting is something like this is now, as we study more and more about epigenetic changes, the role of epigenesis in the origin of or the etiology of many psychiatric disorders, not many, each and every one. We come across something like this, and this is a map, it's an epigenetic map of all the known epigenetic changes when it comes to bipolar disorders. So we have these 5 areas. The yellow one, which is the prefrontal cortex, frontal cortex, anterior cingulate, dorsal DLPFC, and cerebellum. These 5 areas have shown this kind of epigenetic changes: DNA methylation, histone modification, microRNAs, and things like that. So this is a map. Now, what do we understand by this thing? So what we understand by this thing is that it takes a lot of changes, a lot of number of changes. It's not just one environmental insult or one overwhelming event that would lead to the development of a disorder as complex as, let's say, bipolar disorder in this case, because this is a map for that. But what it means is that there are so many kinds of epigenetic changes. Means the DNA component is not touched, but the structures that give the chromosome the shape, the histone core, the other chains, the RNAs. We saw in the diagram that there are certain even before RNA, there is a pre-mRNA, then mRNA, then we have long non-coding RNA. So all these have got an effect on how the cell functions and how the DNA is finally able to express itself in terms of protein. So when you have so many things going wrong in the right proportion, then an individual will develop a bipolar disorder. Maybe a change here or there will not really lead to a disorder unless the change is gross, drastic, complete DNA change. I mean, a kind of a mutation or something like that. So this is a methylation map. This is an epigenetic map of bipolar disorder. Now, another thing is that, as I mentioned previously, that whenever we give psychotropics, our agents also cause some changes like this. We are not going into it. So many of these changes, to an extent, can be corrected by a continuous long-term use of psychotropics, but not all of them. So a topic for a different day, but yes, this is what we need to think about. Secondly, coming to molecular mechanism. So once we have these proteins and different types of, first we focused on genetics and what can be going wrong in the DNA and epigenetic mechanisms. Then we go to molecular mechanisms, means the small things, microscopic things, which are in our consciousness only as, let's say, H2O, but who has seen that H2O molecule? We accept that H2O means water. The only water which we see is the water which we drink or the one which we have a bath with. But yes, there are molecules and there are millions of them, and there are some few hundreds that we know. There are many thousands and 10,000s that we still don't know. But that brings us to the point where we talk about the HPA axis. All of us know what the HPA axis is. All of us know about stress. The question is, how does this stress, what are the things that happen when the brain perceives stress? What are the changes that will happen in the brain and subsequently all other systems of the body? How does this translate into various and different symptoms in different individuals, leading to different psychiatric illness or no illness? So when we look at the basic pathophysiology of stress, we know that HPA is the center. I mean, this HPA thing is known since 1930s, the general adaptation syndrome, Hans Selye, the stress response, and now it's 2022, so 90 years down the line, but we still haven't figured it out completely. So the more we try to figure it out, the more complex it gets. So this dysregulation of the HPA is a common feature among psychiatric disorders. That's why no case, because this will be there in each and every disorder, right from adjustment disorders to anxiety to depression to psychosis to autism to ADHD and lots more substance use disorders and so on. So GR function, that is glucocorticoid receptor function, is important because once you have, let's say, cortisol normally, it is going to bind to the glucocorticoid receptor and then its action takes place. So what we are talking here about is something called as chaperones. Chaperones are molecules which will help in binding the glucocorticoid receptor to the cortisol. So it's a chaperone, it kind of supports. It's like I'll accompany my lady friend to a party and get her back. So accompany, make life easy for her kind of stuff. So what we have here is something called as a FKBP5 protein. Okay, this is one which is extensively studied, and basically FKBP5 is something called as, we'll come to the next one. So here what is important is these two numbers, FKBP5 type 1 and heat sensitive protein 90. So these act as chaperones and co-chaperones, means it's like a whole gang of friends going to a party. Okay.
10 minutes, sir.
Yeah. Okay. Fine. So we have this FKBP5. The important thing is that at a cellular level, FKBP5, which is this yellow molecule, works as a feedback mechanism. It controls the entry of the glucocorticoid receptor along with the cortisol into the nucleus and actually prevents the harmful transcription. This is what it means. More cortisol goes in the cells, it will kind of fire the translation of more genes than needed, and this can lead to toxic pathways. These are the pathways, all these pathways. If they get triggered, it can produce a lot of things across the board. Almost all kinds of non-communicable diseases, including psychiatric illnesses. So what we have found is HPA axis, FKBP5, and this HS90, that is heat sensitive protein 90. It also has an effect. So this is again the smaller version of that. It has also an effect, direct effect on basically this clock genes. Clock genes are associated with circadian rhythms. So like this glucocorticoid receptor has to bind to the DNA to produce transcription, it will also have an impairment in the regulatory cells of the suprachiasmatic nucleus and can cause circadian disturbances. So what we know is now kind of the understanding is quite complete. Stress, hypercortisolemic states, abnormal pathways, abnormal circadian rhythm. So if I am stressed, I might have a sleep problem. So it is a biological, a molecular psychiatric understanding of what happens. Right. Then there are a lot of studies on cytoskeletal dynamics. The proteins that are there do a lot of things. Cytoskeletal means the cell is not, cell has also got a skeleton like we have got a skeleton. If there is no skeleton, the cell will not survive, it will collapse and die. So the cytoskeletal proteins, like this DRR1 protein, down-regulated and renal carcinoma protein. Now this is known to act as a link between stress, actin, neuronal function, cognition. Okay, so we are looking now at FKBP5 was one. There are studies which will say that if there is an FKBP5 genetic abnormality, then you will have an abnormal FKBP5. It will not act as a good feedback mechanism, and it will predispose right from birth a child to experience more stress in situations which are not stressful. And then as the child develops, a lot of other far-reaching effects, various molecular pathways, as they develop, they will not develop well, and a child can land up with an n number of things. Some of it which we would know as chronic stress, which could lead to PTSD or a schizophrenia, or basically a psychosis or a depression. Okay. And then, of course, a general abnormal brain development. So we have also now beginning to understand the role of cytoskeletal proteins. Okay, this is again something about the glucocorticoid and mineralocorticoid receptors. We'll not go into details. So basically, we are understanding a lot of mechanisms, especially stress related. Now we have also actually understood enough of the protein kinase C. We have got endoxifen that is available for us. Okay, PKC inhibitor. PKC, we thought it is one kind of an enzyme, but it has got multiple isoforms. The basic idea is that PKC inhibition stabilizes the hypercalcemia, which is there, the hyperactive cell that is supposed to be a manic cell, a manic neuron. It kind of stabilizes, but it has got its action on the GSK3 beta and so on and so forth. So plenty of actions. This is one target which has actually been developed into a effective therapeutic modality. Okay. Second thing is, what we also understand is whether there are any sexual differences in treatment. It is important to know because we have certain observations, but if that observations are repeated, if they lead us to the same results, then we are confident that this is how it works. So what have people found out? People have found out, these are of course studies in mice, that ketamine is effective more in female mice than the male mice. So there is some kind of a sexual differentiation. Estrogens augmented the effect of ketamine, right? Now, what does this mean is that the drugs that we use may not have the same effects in males as well as females. There are bound to be certain differences depending on the estrogen, circulating estrogen and progesterone levels in the brain, right? So that was about ketamine, but there are studies which are targeting these newer molecules also, which maybe after a few years we'll understand whether they've got gender-based differences in their action. Okay. What we also understand at the mechanism level is that chronic inflammation, major depressive disorder, they're all kind of brother sisters. They all are associated with an increased level of pro-inflammatory cytokines like CRP, interleukin-1 beta, interleukin-6, and TNF-alpha. So in this inflammatory function, there are a lot of cytokines which Dr. Bhaskar made a mention of, which the cytokines basically are important because they direct the movement of cells, different types of cells. So even moving neurons is a task. So when chemokines are there, they are going to have an effect on a lot of neuronal migrations, repair maintenance kind of thing, cell addition, and so on and so forth. And in the pathogenesis of all psychiatric disorders, there are certain migration abnormalities. There are certain adhesion abnormalities. The cells would be in place, but they are not kind of in a good network with each other. So we are looking at that. Biomarkers are important because they'll tell us what do they tell us? They tell us that if this marker is present, then this illness will be there. If this marker is absent, then the illness is not there. If this marker is present, then it will respond to this treatment. If this marker goes away, then it has responded, and so on and so forth. So we are always looking at, as we mentioned before, an interaction between the gene and the environment in all disorders. DNA methylation is the best studied. Yeah, DNA methylation in, as I showed in that epigenetic map of bipolar disorders. So what is mentioned here is it's a kind of a sum of all the things, is that DNA methylation, if we understand more better, we can actually predict an illness. We can actually predict a kind of a treatment response. So a big table, but I'll just focus on the first two. Decreased DNA methylation at this site is associated with poor response to antipsychotics. So if you're able to find this as a robust finding, if you're able to lab test it in a patient, I would know which patient is going to respond and how. Clozapine induced DNA methylation changes in this gene with clinical improvement. So if I'm giving clozapine to a patient, but this kind of a demethylation change, DNA methylation change is not happening, then patient might not respond to clozapine. So a lot of small studies, some of them animal studies, some of them in small patients, but none of them are robust enough to reach my table and which I can, kind of use with regularly use it. Okay. Combination of disorders is very common. So we have CVD, that's cardiovascular disease, and mood, major depressive disorder. Common inflammatory biomarkers, I mentioned them before: HS, high sensitive CRP, interleukin 1 beta, and IL-6. Okay. So whenever there is a higher inflammatory markers, those category of bipolar patients, depressed patients, will probably respond better. Is one of the hypothesis, clinical hypothesis, that is kind of being worked upon. Okay. Right. So people also have used as sleep as biomarkers, because now we understand the neuroendocrine parts of sleep. So this is normal sleep. Earlier part of sleep is GH-RH dominant, and the later part is CRH dominant. As we become old, the GH-RH reduces, the CRH increases. But with a patient of depression, GH-RH remains same, and this CRH, a hypercortisolemic state, predominates. So how does this manifest clinically? This manifests clinically as dense REM sleep, because that CRF is more, and any antidepressant which reduces REM sleep should reduce that REM. So we know that if we use that, it can be a marker. An EEG marker called as cordons is also important. Okay. Another one that people are actively pursuing is BDNF levels. BDNF level are decreased in depression and mania. So with treatment, it should increase. But what happens is that more the number of episodes, the more there is depression of BDNF. So it may not come to baseline. That's where we could have a residual illness, which would manifest in various forms. Drug response. Okay. Again, FKBP5. Now this FKBP5 is going to come again and again. So those of us who are interested in understanding the stress and its effects and how it manifests over the lifespan and what happens with medication, with illnesses and all, FKBP5 literature is to be followed, especially the last 10 years, a lot of understanding. So again, here they have used FKBP5, and this polymorphism of FKBP5 has an association with non-responders. Animal models is what actually brings us to the lab, because we cannot directly test all these things in the human brain. Clinically, we are not able to correlate this symptom means what in the brain actually. So we have animals because they are more simpler. They've got simpler nervous systems. The mice are simpler than us. That is what we believe actually. may not be so, but at least for the research purposes, for the lab purposes, they are simpler models. And actually we can have different types of mice. We can genetically modify them. There's something called the Roman high avoidance and Roman low avoidance rats, which have different kinds of expression of BDNF when they're exposed to stress in the dorsal hippocampus and the ventral hippocampus. So if you have got these specific models, we can have some idea what must be happening. Then human studies, but we cannot really keep on having brain specimens because that would be problematic, unethical, and so on. So we need better tools, but this kind of things lead us to different kinds of hypotheses. What are the methods that we use? Because this kind of things we generate a lot of data, lots of variables, and how do we put all of them into place is called as big data management. So there are different kind of networks. There's this multitask learning with network structure, and there is a support vector machine. These are different models of big data analysis. So this is too technical, but well, we need to be aware because we are going to keep on hearing about big data analytics and stuff like that. If we read about it, if we spend more time, it will be easy. But well, this will be a kind of a CME by itself of what psychiatrists or neuroscientists do when we deal with big data analytics. So for that, but there are different models. Okay. And then there is something called as, this another technique is now people have started trying to, understand the behavior of induced pluripotent stem cells. What are stem cells? They are there in all of us, even when we are growing older. And these cells are basic cells, means given the right stimulus, they can develop into the kind of cell that we want. So this reflects our fetal status. So let's say skin fibroblast. You give them the proper electrical chemical stimulus and they will develop into a neuron. So the idea is, if we are able to understand the genetics and the epigenetic markings in induced pluripotent stem cells, we would know right at the fetal level what is the genetic makeup, what are the epigenetic changes that have happened, and how they will manifest, because now we are getting them from an adult. So this is one way of looking at the genetics of psychiatric disorders. Just before I end, this is one thing which was fascinating, is when human induced pluripotent stem cells, neurons, were studied, okay, compared with normal individuals. Okay. So now that group of patients has got schizophrenia diagnosed, and there is a control group of normal individuals, and we study the electrophysiological properties of the stem cells derived from both. And what we find that in patients with schizophrenia, they have got altered sodium channel function. There is an action potential interspike interval which is more than normal. There are abnormalities in GABAergic neurotransmission, and this is the basis of the cognitive and the cardinal features. Actually, if you are able to get this, then it means that the schizophrenia is right from day one of the person's life. So in utero, fetal, yes, what we look at symptoms is maybe 20-25 years down the line. So it's a long time that goes. With that, I end my presentation. I just believe that I'm not overshot by many minutes. Thank you for a patient listening. Over to you, Nachiketa.
Thank you, sir. It was only 1 or 2 minutes over. I request chairpersons to say a few words.
I think this has been an excellent session, all three of them. We'd like to invite audience into the interaction. We have some time for it. Dr. Kaushik, you want to say anything?
Yes. Before we throw it open to the audience for questions, I have a questions for Dr. Malay Dave. As he said that many symptoms are present well before the illness becomes apparent. For example, he gave the story of schizophrenia, where maybe a boy with, say, 11 or 12 years old presents with behavior which has been noticed by relatives to be aberrant, cognitive slowing or decline. So, and schizophrenia has not yet happened. This person is presented to us. How do we take it forward?
I think the only way we can, given the whatever literature we have, given the understanding, the clinical understanding, I mean, is, well, there is something going to be called as a high index of suspicion. Okay. Now, whether I would want to start the patient on a medication, I would not be very confident because we do not know where it is heading. Because we do not have a, as I said, 100% sure certain that this is going to, from this stage, it's going to here. Many times those things are set and they follow. So it's actually very difficult to predict. We do not have those kind of prediction models, which will tell us what to do. But basically, when somebody like this comes to me, the idea would be to keep a watch on how this individual progresses, how he or she is dealing with academics. Basically, that is the major stress that somebody who's in that school going age would have. What are the challenges of the developmental period? Early years would be, maybe let's say if I'm seeing some cognitive impairment in early school days, let's see how the child has, the individual is going to negotiate adolescence, the changes of puberty. So good watch. I mean, if I'm allowed to say, if we have got kind of those care models that we read about in Western literature, probable psychosis or early psychosis or at-risk psychosis, those kind of setups, you can have a monitor. Maybe then only will be wiser clinically.
Dr.
Can you add
Kaushik,
something?
Sir, the audience question.
Dr.
Please
Kaushik,
name
may I say something?
Yes, sir. Yes. Why, yes, sir.
Yeah.
Dr. Kaushik, your question is so relevant, and this has been bothering me as, out of 45 years of psychiatry, that there is no doubt that major mental illnesses are genetically determined. They have a developmental component. It's almost like a person is born with the disease. So what do we do if we do all these investigations and tell a parent that you've got a child who's just 2 months old today, but 45 years down the line, he is going to be a schizophrenia beyond repair? We can't do that. It's like, telling the person that, what is it that we can offer? So the metaphor that has been coming to my mind is to compare all these data like, it's a seed and soil mechanism. And we are going to be able to identify somebody who's at a potential risk of getting some major mental illness, where the soil, that is the nurturing of the child, would then be of great relevance. So probably, I'm making a guess, probably if we do have markers in early childhood or adolescence that would help appropriate upbringing or parenting, we cannot be treating such a person for whatever the presumed illness that will crop up in the future. That's my way of looking at. What do you have to say?
Absolutely, sir. What I was
Yes,
thinking
sir. May I chip in?
at-risk psychosis has a certain at-risk for psychosis has a certain percentage of conversion into schizophrenia. Say, let's assume for the sake of argument, 50%. So we have to be very careful about what intervention we even contemplate suggesting to the parents, because there will be 50% for whom it will be completely futile.
Yes, sir. May I chip in?
Ramana Rao from Andhra Pradesh. This question is for Dr. Shobhit Garg. Sir, whatever studies that have been conducted in the institutions, can we really translate into our day-to-day clinical practice? Because even the state governments are now sponsoring these RTMS treatments. And I understand that without the neuronavigation and without the functional MRI support, can we give the accurate results to the patients? Or is it going to be more of a hi-fi, technical treatment, which is now being claimed by big centers, both in private practice and they're charging huge money? The way you were talking about 250 rupees per session, I don't think that's not happening in the real time. Thank you very much. Your comments, please.
Good, sir. You brought this up. That is why I actually put that slide for pragmatics. Now, what is important is key with everything taken into consideration, we can still actually make it more affordable for the patients. Because again, therapeutic conversion from an ideal setting to pragmatic setting or community setting, we are not sure. We don't have data, clinical data. The clinicians who are practicing it, we don't have that kind of a data, how effective it is. It is only from some tertiary institutes like CIP in EMHANS and the labs. We have a RTMS lab here. So we collect data, and those are only short-term trials. So they are for a month, maximum for a 2-month follow-up, and maximum among all the neuroscience, including neurology, 6 months follow-up. They have actually done for RTMS studies. So the conversion is questionable, but one thing is sure that it is safe, and definitely it is effective in depression as of now, and it has a lot of scope in other disorders. So that should and the cost factor. If we forget neuronavigation, we have not used neuronavigation till now, but we have managed to actually do a lot of research in these patients. So I think we can use it in clinical settings.
Dr. Bhaskar had something to say.
First, let me clarify, there is no schizophrenia, there is no bipolar. This is DSM diagnosis. And DSM is just a list of symptoms. So any patient who at the age of 10 years is showing signs of cognitive decline, signs of other things, are going to develop something else. Either so-called schizophrenia, so-called bipolar, so-called recurrent depression, so-called obsessive compulsive symptom, anything. Standing there, it is unwise and morally wrong to not treat this child. Now, what we have, do we have anything from all over world, early psychotic clinics, first episode psychotic clinics and anything? All over world, their published data indicates that the risk of conversion to various later age symptoms can be prevented by giving antidepressant with or without CBT. So we actually can prescribe antidepressants in this patient rather than saying that 50% would convert to this, 50% would convert to this. No, there is no percentage. It's a personalized, risk-based, genetics-based assessment. And for each individual, it is different. Standing there, if we talk about molecular psychiatry, if we talk about molecular genetics, if we talk about things which are really happening in brain, then we should not talk about like this. Thank you.
Thank you. The chairperson, sir. Dr. Alim, Dr. Kaushik Saab.
All the mental illnesses, and now we feel that genetics is the major thing which can be blamed for mental disorder. Now, practically, what can we do for changing this genetics? Do we have facilities for genetic engineering? Long back, I think our Nobel Award winner, Dr. Hargovind Khurana, had discussed about some genetic engineering and all that. But at present, after blaming this genetics, what can we do to change this genetics in day-to-day practice? My question to Bhaskar, please.
All our psychiatric drugs, whom we treat as pariahs and whom we hate to give to patients, are drugs which changes genetic functions in body. Every one of them has their own function at epigenetic level and genetic level. Any drug, give me any drug, name anyone. Dear chairpersons, please volunteer to give name of one psychotropic. Alim, give me one name of one psychotropic.
No, I think we'll not name anyone. We'll take everyone's name.
No, any psychotropic.
We are not there to answer questions here.
Okay. Any psychotropic, let's say I am talking about the least discussed one. Yes, thyroidazine. Nobody talks about thyroidazine and genetics. Thyroidazine is a drug which has a lot of epigenetic actions. It causes demethylation by inhibiting DNA methyl transferase as certain areas of body. It causes deacetylation by inhibiting protein binding to deacetylate histone. It causes removal of hypermethylation from CpG island by again interfering with DNA methyl transferase enzyme type 3. So you see, give me name of any psychotropic and I would lead to a variety of epigenetic actions done by that drug. And what I would tell is just less than 1% of what that drug can do. Because believe it or not, our understanding in this sector is less than 1%. Our DNA has two parts. One part, genes which are producing proteins. These are less than 2%. Let's say 1.5 to 1% of DNA. The rest of DNA is just regulating element which regulates this genetic function. We don't know what our drugs do at the regulatory elements, which is 99% of DNA. So our drugs probably do much more than we can give them credit for. But all our lives, we had been taught to hate our drugs, to treat them with suspicion, to say they don't work, and to be apologizing to everyone for using psychotropics which are addicting, which are bad, which are sedating, which are causing this and that, which are causing brain degeneration, which are causing hepatotoxicity. Most of these are bullshit. Our drugs are one of the most prominent health promoting agent that humanity has. If we accept that, we can do a lot of things.
Does that answer your question, sir?
Maniyal sir.
Thank you.
My question is a simple curiosity that what protects the female child, because we don't see a lot of cases of autism and ADHD in girls. So at molecular level, what is happening that girl child is protected from autism and ADHD?
Malay sir, Bhaskar sir. Gender differences in ADHD and autism.
The thing.
Yeah, Bhaskar, carry on.
First, we have to understand that we are not seeing girl child. That can be due to three reasons. Number one, false low detection. Girls are not given importance enough to bring to clinicians. Number two, some true protection that girls get. And number three, it also might be something that girls might get very severe illness more, so that their parents and their caregivers are not really interested in treating them. We don't know which of them are true. Probably all three are true.
I'm just curious actually about one thing.
Could you identify yourself?
Yeah. My name is Dr. Prashant Chaudhary. I'm practicing in Mumbai. So I just have one question that considering the epigenetic nature of psychiatric diseases, can Barker hypothesis, which states that early life nutrition increases the propensity of some physical illnesses in a child when the child becomes adult, So can the Barker hypothesis be applicable to psychiatric diseases as well? And prenatal environment of the mother, can it determine the propensity of getting a psychiatric disease or not?
Question to all the speakers. Would they like to take it on?
The thing that if I can go first.
Yes, sir.
Yeah. The thing is
Please
that
go ahead.
the thing is that it would be too simplistic to say that a certain factor will protect or prevent something, because we are learning a lot of things. I mean, if you look at good maternal nutrition, one. But the question is that these epigenetic factors, they don't happen in utero. They have happened before conception. So then what do we do? So by giving some things in pregnancy or by not giving certain things in pregnancy, we are doing a very little bit of manipulation which may not be effective. So what I would suggest is that at this point of time, all these things, I don't think they are sufficient to prevent anything. That is my bottom line.
Yeah. Let me, I think, just put a few points. The session that we're talking about is not as much on changes in intervention as it is on understanding the language in which we look psychiatry, we talk about psychiatry, we look at psychiatric symptoms. So, for example, if we say that this Ancips is going on, and last Ancips was at Kolkata, and we are comparing the two. So this is the very gross overview or a sort of overgeneralized things that we are talking about. Now something is happening in this hall. I am sitting there. So what Shobhit, Bhaskar, and Malay, Dr. Malay are talking about is we now need to look at psychiatry from this angle, that the depression is not starting at 25 or schizophrenia is not starting at 25 years of age. It is probably starting in utero. Some symptoms might be there, we might catch them, we might not catch them, and it evolves to a proper full-blown disease later on. So how we look at the symptoms, how we look at our diagnosis, how we need to revisit how we are working on it. I think that should be the mainstay rather than asking the speakers what to do. What to do will come later on. First, we have to accept how we are looking at psychiatry is probably wrong and we need a course correction. After this course correction, we might get more results, more thing. I think based on this, if we are able to change your genetics, if we are intervene on your genetic profile, I think that would be the way to go. Any comments from speakers?
I think that's the correct way of looking at it, because as I said, just to start with that, when we look at basic sciences, it appears very intimidating for most of us. The language is different. You know, why am I looking at something which is just in the form of some diagrams or schematics and how it is going to manifest as a symptom? I mean, we are understanding. It's not a full stop yet. I would not say we are even completely on the course. So yes, we need to give it a lot of time for these things to give us better results, to make our understanding more clear and concrete. And that is when we'll be able to say with confidence what actually is the illness we are dealing with, what actually are our agents doing, or what our intervention modalities are doing, and what they're not doing. Both the things we need to know. Whether we can develop some things better, whether we can develop modalities. I mean, see, prevention happens only when we understand the complete thing. To give a very simple example, unless and until we understand what is polio, what causes polio, and is there a vaccine for polio, and if everybody gets the vaccine of polio, then and then only can it be eradicated. Now, psychiatric illnesses are not simple as that one virus causing something. There are multiple things. So unless and until the the understanding, the etiogenesis is clearly understood, all the factors are in place, not in place in our heads, leading to that, can some strategies be thought of maybe so many years down the line as truly preventive?
Very well said, Dr. Dave. All our patients of depression come and complain of sleep disorder, but what part happening at a very basic cellular level impacts the sleep, we are still grappling with. So there are some more questions from the audience. Please go ahead.
May I be excused? I have to actually go back to my clinic.
Picked up the mic. Do you wish to ask a question? Yeah. Yeah.
Chairperson, sir.
Dr. Bhaskar wanted to say something.
In the same topic, is female brain at molecular level different from male brain functionally?
In single word, yes. In single word, yes. I am not going into detail word because that would cause a new CME of 7 days.
There are a lot of differences in the functioning of the brain, if I am allowed to just continue what Bhaskar has said. But yeah, it is not the purview of today's topic at all. So we'll just leave it at that, yes.
Okay, thank you.
To our chairperson, I think Bhaskar sir for asking something.
Yes, I have to leave. Patients are getting violent.
If
I might get ambushed now.
chairpersons can permit Bhaskar sir.
Patients are getting
Are there any
violent
questions
now.
for Bhaskar? He can answer and leave.
Okay.
Thank you so much, Dr. Bhaskar. I hope
Thank you,
others can
Bhaskar.
stay on if there are any more questions. Yes, somebody's asking a question online, but we can't see you yet. No. Okay.
The question is not yet available in chat box, I think.
Any questions in the chat box?
No questions.
No,
I
sir.
can't see anything in the chat box.
Okay. No. Okay, to Dr. Shobhit, you talked about neuro modulation and stimulation. So suppose a patient gets better, how do you maintain those improvements?
So there is no holistic approach, like one defined scientific approach. It is yet to be studied. But one of the authors very vividly said that if we are giving RTMS sessions, maybe 5 sessions in a week, then you go for 4 sessions in next 2 weeks, then 3 sessions next 2 weeks, then 2, and then 1, and then alternate for 8 to 9 months. And then actually that they have brought out their data, but it has not been replicated. But that appears to be like as we are giving an antidepressant in acute phase, and then we are tapering it off. For maintenance phase, we bring it to an optimal dose. So maybe that kind of an approach will bring sustainability to brain neuromodulation techniques and their effectiveness.
I have a question for Dr. Shobhit.
Yes, sir.
Neuromodulation is being discussed on various platforms, perhaps not as vividly as you did today. The point is, what are the chances of recurrences and relapses after neuromodulation?
Sir, pretty high because they have not actually followed up. The maximum followed data is 6 months, sir, in the trials among all the neuroscientific disorders.
Right. So that is the literature, but your experience?
Sir, generally, sir, when we discontinue, because we are giving an intensive trial, we give 2 to 3 sessions per day. For a week, we wind it up. Then they become better, they remain better for a month or 6 weeks. And then, sir, if we get this window, we optimize the drugs. At times they maintain well, and at times they can relapse, sir. So it is an even kind of a situation here, sir. Because we are not solely giving them RTMS or brain stimulation. So we are actually using it as an augmenting agent. So then we optimize the drugs also after that, and they remain better. But few of them, they do relapse back, and then they request for maintenance treatment, which can be a little difficult on them as far as the finances are concerned.
A question to Shobhit.
Yes, sir.
Would you like to, when you give this neuromodulation treatment, you continue psychopharmacology or not?
Yes,
There is
sir.
one. And if we compare the psychopharmacology and neuromodulation both, which one is better, according to you or according to the literature?
Sir, psychopharmacology, sir, the point is that we are using neurostimulation as per the clinical staging model. where we are using it to most of the patients who are not responding to the conventional agents available, or they are not tolerating those drugs. So when we generally add it up into the regime, when patient is on some antidepressant or antipsychotic or a mood stabilizer or at a tolerable level, and we add it up, and then we see, and we add it up, and then if patient shows improvement, then we continue, we taper off these RTMS sessions, and we continue the patient on the the drugs or the pharmacological drugs. That is the approach that we do. But long-term data, because we have not collected it, what happens to them after a year or 2 years, we don't know, because of the lack of follow-up data here also. Clinically, I might be biased because many patients might get dropped out. They don't come to the follow-up in the OPD. So I would only see those patients who are actually coming to me, who had RTMS and improved. So my perception then might get a little biased in that sense.
So can I extrapolate that the thing Bhaskar was saying, you need to give medication for the longest period of time. So you need RTMS for the longest period of time?
Yes, sir. So if required, if they have responded only to this, so why not?
And practically, how good do you find it in real world practice? And any specific type of patients in which it was more useful? So
Sir, it is
very sort of coarse question, but if you can answer.
So depression and migraine, headaches, actually PGI data, SG-PGI data, even one session of migraine, they have actually had patients in remission. Very interesting data they had. So we started giving it in migraine and they actually improve. I don't know whether it is a placebo effect or it is underlying the neurobiological mechanism, which it has, but it is very interesting. These two populations, they respond robustly on RTMS.
So you said there are 3 kinds of RTMS. What is the RTMS that you use for the migraine patient? Was it the deep or?
So we don't have deep coils. So we only use plain figure of 8 coils. And then we have a double cone coil. And so we actually using little stringent measure for RTMS, more robust version of it, that is theta burst, where in 50 hertz frequency, very fast. So it is more closer to ECT. It's like a focal stimulation of an area, which is actually very strong. So in that sense, and it brings up very quick benefits also, because a routine RTMS session might take an hour, but this theta burst will get delivered in 3 to 5 minutes.
Are neurologists also using it?
Yes, sir. So probably more than us. They are using it in stroke rehabilitation. It has come up in neurosurgeons are using it for cortical mapping for surgeries now.
Sir, which make is generally being recommended by your institution for our Indian patients? Which make? Is it the Indian make or there are several makes available, brands available, no? European brands and then American brands, Chinese brands.
Sir, sir, nicely you brought this question, because I dialed up all these Indian companies representatives. Where do you get the recognition from? Because FDA recognizes those manufacturers' machine. Okay, Neurostar for depression, for basic deep TMS machine for OCD. So FDA actually recognizes that manufacturer and a particular indication. But we don't have any kind of that body like this. They only get a ISO certification, but there is no body here which will actually recognize these machines. So as of now, we are using here MagVenture. So I would not recommend Indian machines because they're not actually affiliated to any credible association for clinical interventions.
Our Indian setup, how much financially viable the finance, because the charges which we will be taking in the patient, particularly in Indian setup where most of the patients are middle class or lower class, financially viability.
Sir, that is what I shared. I calculated it. So I shared that for Indian patients, if we charge 250 rupees per session, so we'll actually equal up the cost of the machine. So maybe we can go to 500 or 750 to cover up everything. And 10 sessions, so it will be around 7,000, 7,500. And if it brings benefit to the patient, so what better than that? And specifically, we'll be using in those patients who have actually not got much of the improvement visiting a lot of places. So they might buy this effort from our side.
So any other questions from the audience?
From what Dr. Shobit says, besides
Any
the
concluding
machine being
remarks from the
certified,
speakers, and then Dr. Vahia, sir.
from what Dr. Shobit says, besides certifying the machine, we should also standardize the prescribers of the therapy or the administrators of the therapy. Because it's just not good enough to say, go for RTMS. We have to be able to specify what kind of RTMS, how many sessions. We need to learn how to prescribe RTMS before the machines are certified.
Yes, sir. So to continue this point, sir, PGI has a list, sir, of the disorders, the maximum indicated session details, and they actually they're displayed in their website and to all the residents there, and then they subsequently correlate this delivery of RTMS there.
Vahia, sir, should we as IPS make certain white paper or guideline regarding this, so that this RTMS becomes a psychiatric treatment rather than a neurosurgical or a neurological intervention? Your comment.
Dr. Alim, you have raised the point which has been on my mind. Now, thanks to Dr. Alka, for example, we have started having a certification course. This time we have had it on sleep medicine. We ought to have something on RTMS, specific on RTMS. Somebody can actually do a course where people pay for it and learn what RTMS is all about. If we once learn it, it's all ours.
Yes.
But at this point in time, we have not learned it. So kind of, so many things are mysterious. And some people who have got RTMS machines, it's become more a, kind of a money spinning machine than a symptom relieving machine.
Yes.
Yeah, sir, actually that was our first choice, but because of COVID, this hands-on treatment, hands-on training stopped.
Yeah.
So I think I'm also on that committee. So
you are also on that side. Yeah, I'm sorry. You are also on that.
One of the top priorities that if we are able to get this hands-on training, it will be a very useful course for us.
So RTMS needs to be, Dr. Alim, I think you're the right person. Do go in for this specific training. I mean, let people know what they're doing before they start prescribing it.
Sir, can I add, sir? Sir, I had an opportunity to see these machines in APM Meet in San Francisco. Later, I was invited to attend one of the workshops, hands-on workshop conducted in Hyderabad by a neurosurgeon and their team. At the same, Chinese people have installed their machines, and we had 2 days hands-on workshop. It included people around from surrounding countries also, like Bangladesh, Sri Lanka, and all over India. All the neuroscientists, including the psychiatrists, were invited. It's a good experience. But the thing is, the team of the speakers are from China, and they don't know the English. But our neurosurgeon friend, who was trained in US, he has translated and done things. But unfortunately, because of COVID, that has been stopped. And there is a rift between India and China, and their machines we are not able to purchase now. In fact, I wanted to install one. I couldn't do that. So I had an experience with that, hands-on experience. I think as an IPS, we should require regular training for all the young psychiatrists before they really install it. They require training. Without training, I think it's meaningless to prescribe it or to do it also. Thank you very much.
Sir, in continuation of this also, I'd like to make a point. Any side effect like seizure, the Modulation Society, it says that it has to be reported via some credible journal. So any side effect with RTMS, which is a credible side effect, it has to be reported. This is as per the consensus and the guidelines. So this is also very important here. Because if we don't deliver it properly, we might actually invite side effects also. So training is very important.
So Vahia, sir, any concluding comments on all the 3 topics?
My personal apprehension is that, we get these things in waves. 5 years ago, there was this wave of stem cell therapy. And then it's thrown out of the window. So I don't know. Then there was this ketamine. Everybody said ketamine. 2 years ago, everybody talked. Anytime you talk of depression, the session talks of ketamine. People now don't talk about it with as much enthusiasm. So is this one of the fads that has come and gone or may go, or is this something which is substantial, which will stay? Because at the end of the day, we are not going to be able to give a long-term benefit to the patient. You feel good for the time being, and then you get sick again. And then you have to take drugs anyway. Then what? I have no answer. It's just questions on my mind.
So it will stay.
Sir, my uneducated guess would be it will stay. My uneducated guess is it will stay. Show with your educated guess, please.
Sir, it will stay if we don't lower our standards and we don't fall for those unstandardized, uncalibrated Indian machines. It will stay.
Absolutely.
It will possibly also stay if we don't use it as one size fits all.
That's
Now,
it.
all
You
those
got it.
things which are
You
not
got it.
responding, RTMS ke liye bhej do, that is very unscientific. And some of that is happening, as you're probably aware.
This is a very fine science. It's a super science, and we've got to have that super skill to use the super science. Otherwise, we are going to end up with asking a scooterist to drive a tank. It doesn't really help.
Shobit, if you can send us some sort of communication to the committee regarding this RTMS, and if you can be a trainer on that.
Right, sir.
I just wrote to Shobit. I'm going to invite him to Mumbai. It's too much for me to reveal it, but Shobit, I don't think you're going to get away with this very easy. You're going to come here and teach us all.
Pleasure, sir. Pleasure.
So I think there are no questions from the floor now. I think we can start concluding. Vaya sir, any comments from you, or we can close now?
So mine is a general comment. When we were planning this CME this year has been very unusual year. Both the CMEs have been hybrid, and there were a lot of insecurities. And it's interesting that the enthusiasm of our colleagues to attend the CME has remained undaunted. That was very, very encouraging. And unlike some of the past CMEs where we had 5 minutes or 15 minutes of talk and 5 minutes of discussion, we opted to have long discussion on every session. And the CME, the way we planned it for this year, the annual CMEs, we wanted skills training as well as practice-oriented information. So the skills training, we had two. We had this telepsychiatry in the morning, which again is a very fine skill. If it is not used properly, it's going to fall kind of backfire on us. And this session on neuromodulation and molecular psychiatry. And the other hall, which probably some of us wouldn't have attended, the morning session was on NDPS, where we had not just the doctors talk to us about NDPS, but we had a senior police officer to tell us about the police version of NDPS, its implementation and obstacles. And just now, as I'm talking to you, we have a session on suicide prevention and advocacy going on. I mean, I've in front of me, I've got 2 laptops. So I'm seeing what's happening in the other hall, and they're also going through question and answers just now. And seems to be that they also have a lot of questions on advocacy, on predictions, on prevention. So our attempt so far has been that we all sit and learn together, and some amongst us teach the rest of us. That seems to have worked out. And I must make a comment on the chairpersons and the moderators of all the sessions that we have had. It's been exemplary. In fact, for me, at the age of 72, I would say this is the best CME that I could have ever attended or thought of. Thank you very much, Dr. Kaushik and Dr. Alim. And please convey my personal congratulations. I've done it already to all the chairpersons. It's been a wonderful experience. Thank you very much.
Thank you so much, sir. Thank you so much. It was actually a very pleasant experience being here. Despite feeling drowsy, we were kept awake because of the deliberations and the coffee that was supplied here. So thank you all audience. Sir, any remarks from you?
Firstly, I apologize on behalf of the organizing committee for the little imbroglio we had in the beginning about the shifting of the halls and all that. But then once begun, it took off like a rocket, and I think everybody was engaged, and there was so much to learn, so much to know. And as you saw, we discussed so much. And this is what I think it's all about. We have to try and understand the science of it more and more so that we can transfer that benefit to our patients. With that, thank you all for attending. Thanks particularly to the speakers and especially to Dr. Vaya, sir, for putting together such a fantastic program for all of us. Thank you.
Honored, sir. Thank you very much, sir.
With that, we close the session. Thank you.
Thank you, sir. I request Dr. G.V. Ramana Rao to present a small memento to the chairperson, please. Jaiye.
Dr. Alim, please also thank the moderators on my behalf.
Dr. Nachiketa behind the scenes, from the morning he knew what was what, and before we figured out that the halls had been shifted, he was the one who was completely on the ball.
Yeah, thank you so much. I think your mementos will reach somehow to you. We were missing you here. If you were all here, it would have been even more wonderful. So thank you, Nachiketa, Dr. Malay, Dr. Bhaskar, Vahia sir, and all the audience. Shobhitya. And we close the session here. Thank you.
Thank you.
आपको कोई